Good day. I would like to speak to you today about the role of global surgery, anesthesia, and obstetrics in the SDG era, and the role of surgery, anesthesia, and obstetrics in universal health coverage. In 1980, Halfdan Mahler, who was the Director General of the World Health Organization, was the first major leader to link surgical care, health equity, and social justice. This was a bold statement for the time. Many years later, Paul Farmer and Jim Kim also emphasized the importance of surgical care and in fact called surgery the neglected stepchild of global health. In 2015, Disease Control Priorities 3, the Lancet Commission, and the World Health Assembly Resolution 6815 were passed. This resolution emphasized the role of essential surgical care and anesthesia as a component of universal health care. More recently, in 2019, Dr. Tedros, the Director General of the World Health Organization now, also recognized the importance of surgical care and universal health coverage, stating it is therefore vital that countries invest in surgery. Now I would like to show you a video from Dr. Tedros.
Lord William Itangi, Professor John Meara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen, greetings from Geneva, and thank you for the invitation to speak to you today, and I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
I would like to now review the findings of the Lancet Commission on Global Surgery. First of all, the Commission defined a vision: universal access to safe, affordable surgical and anesthesia care when needed. The Commission also had 5 key messages, which were quite startling, and defined 6 indicators that countries should collect to mark the progress in global surgery. The other important recommendation from the Lancet Commission was that all countries should have a national surgical, obstetric, and anesthesia plan. In terms of the 5 key messages, the Lancet Commission found that 5 billion people do not have adequate access to surgical care. The second message: 143 million additional procedures are needed to meet the needs of the poor. The third message: 81 million people face catastrophic and impoverishing expense seeking surgery. The fourth message was an economic message, that yes, there's an investment required in surgery, possibly up to $350 billion over 15 years. However, the potential economic benefit could be on the order of $12 trillion for emerging economies. And the last message was a quote from Jim Kim, who was the president of the World Bank and said that surgery is an indivisible, indispensable part of healthcare. All of these things are very important because approximately 1/3 of the global burden of disease is related to surgical conditions. Because of this, the Commission recommended 6 indicators. First, what percentage of the population is within 2 hours of access to appropriate surgery? Second, what is the surgical workforce in each country? Third, what is the surgical volume in each country? And the fourth, what is the perioperative mortality rate in facilities and in each country? And the last 2 have to do with both impoverishing and catastrophic expense. And what is the economic impact, the financial impact on people who are seeking surgery? The Commission also looked at the workforce in each country and plotted surgical workforce and looked at life expectancy and other World Bank outcomes. And the Lancet Commission found that when you add up surgeons, anesthesiologists, and obstetricians, and we define this as the SAO provider density, so surgeons, anesthesiologists, and obstetricians per 100,000 people, and you look at World Bank outcomes, countries above 20 SAO providers per 100,000 tend to have better outcomes than countries below 20. So possibly 20 SAO providers is a rational goal for countries who are well below that level. It is clear that more providers are not necessarily always better, and countries that are above 80 to 100 or even more than 120 providers per 100,000 do not necessarily have better outcomes. We then worked with the World Bank and talked to them about their World Development Indicators and noted that in the health section of the World Development Indicators, there were no indicators for surgery. We then collected data, and the bank has now published data on workforce, surgical volume, impoverishing expense, and catastrophic expense, and these can now be found in the WDI section of the World Bank. The World Bank was also very good at alerting the global health community, and there were several data blogs published by the World Bank. Of note, surgical workforce is now highlighted in the Atlas of the Sustainable Development Goals from 2018. The last recommendation that came from the Lancet Commission was around national surgical obstetric and anesthesia planning. And we defined 6 pillars or domains that countries could look at in terms of making a strategic plan for their country: workforce, service delivery, infrastructure, information management, finance, and governance. Since 2015, a number of countries have gone through this process, and for example, Zambia now has a national surgical obstetric and anesthesia plan. Tanzania has also accomplished this and has a costed plan that is now part of their national health plan. You can see here the plan that Tanzania created and the process they went through, involving all stakeholders, a technical workshop, a writing group, a costing process with their financial ministry, and a final draft that came out in 2017. This gives an overview of countries. We are now working around the world with ministries of health to collect further data on surgery. This will be important to mark progress. There is also an evolving trend towards regionalization. So, for example, the South African Development Community just passed a resolution in November of 2018 that all SOTIC countries should have a national surgical obstetric and anesthesia plan by the end of 2019. And funding, of course, is also key. And we are working with the World Bank and the Global Financing Facility and other bilateral and multilateral funders to fund these costed plans as a part of their national health plan. It is also very important to note that surgery is an integral component of SDG 3. The global health community will not achieve SDG 3 unless we incorporate surgery, obstetrics, and anesthesia as an equal partner in care delivery. And also, regarding universal health coverage, surgery, obstetrics, and anesthesia are critical for equitable access to quality care. Financial risk protection must be considered for surgical care, and it is critical that we include measurement and accountability for results. Thank you very much, and please visit our website at PGSSC.org for any further information on national surgical, obstetric, and anesthesia planning and the progress that is occurring throughout the world. Thank you. That have made some commitments towards national surgical planning or are in progress or have completed the progress already.